Hello everyone, I'll be doing a series on Harrison charts. This is something I wished somebody had done for me during my preparation. So I'll be covering 10 charts from Harrison for video, and there is one request like how to study these, right? So what I'll tell you is to do the chart and just go through the topic. I'm not saying not even go through, just scan through the topic either from a notes or from a standard textbook from Harrison or maybe Davidson, whatever you might have read for your undergraduate preparation. Doing these charts will also clear some of your concepts plus also help you answer many of the MCQs. So let's get started. So coming to holosystolic murmur differential diagnosis, onset of S1 terminates at or beyond S2. So systolic murmur is between S1 and S2. So holosystolic means it is present throughout the system. So it starts with onset of S1 and terminates at or is beyond S2. Now, when you have a holosystolic murmur, so if the maximum intensity is over apex, radiation to the axilla or the base, A2 not heard over apex, and decreased intensity with nitrates. So if all these features are there, these are features of mitral regurgitation. Now, in mitral regurgitation, if there is hyperdynamic left ventricular impulse and wide splitting of S2, S2 is split into A2 and P2, it is wide split. Then there is primary mitral regurgitation, example rheumatic uh, valvular heart disease and ruptured chordae. If there is sustained, so now what is whether it's primary or secondary mitral regurgitation is based on the cardiac impulse, whether it is hyperdynamic or sustained. So hyperdynamic and sustained, what is the difference? How will you find out? I want you to read that. It is based upon the duration of the systole. If it is less than half or more than half. So what I wanted to read, I will not tell you over here. So that's your homework. A sustained left ventricular impulse. So that is simple S2 or a narrow splitting of S2. So there is secondary mitral regurgitation, that is dilated cardiomyopathy, papillary muscle dysfunction, or late stage of primary mitral regurgitation. So what is primary mitral regurgitation and secondary mitral regurgitation? Primary mitral regurgitation is due to the defect in the wall itself, the destruction of the wall of the caudate tendon. And secondary mitral regurgitation is due to basically the angular dilatation. That is might be due to MI, due to cardiomyopathy, due to muscular dysfunction. Now, if the holosystolic murmur maximum intensity over left sternal border, radiation to epigastrum and right sternal border, increased intensity during respiration, and prominent CV wave and sharp Y descent of jugular vein pressure, it is tricuspid regurgitation. So now, in the tricuspid area, if it is heard, it is tricuspid regurgitation. Uh, the right-sided murmur usually increase during inspiration and left-sided murmur increase during expiration. So now, if there is a parasternal prominent left parasternal diastolic impulse, normal brief left sternal systolic impulse, normal P2, and rarely paradoxical S2, it is primary tricuspid regurgitation. Sustained systolic left parasternal impulse, narrow splitting of S2, and marked increase in intensity of P2, palpable P2, is secondary to pulmonary hypertension. Now, we have covered important causes, that is MR and TR. The maximum intensity over left, third, and fourth interspace, widespread radiation, palpable thrill, decrease in intensity with nitrates, no change in intensity during inspiration, wide splitting of S2. It is favors ventricular septal defect, often difficult to differentiate from mitral regurgitation. So this is how would you approach a holosystolic murmur. So if you understand this, you'll be able to answer the question. So this is a relatively simple chart that is drugs associated with edema formation, that is NSAIDs, antihypertensive agents, direct arterial or arteriolar dilators like hydralazine, clonidine, methyl dopa, guanethidine, and minoxidil, CCBs, and alpha adrenergic antagonist, thiazolidine dione, steroid hormones like corticoids, anabolic steroids, estrogen and progesterone, cyclosporin, growth hormone, and immunotherapies like interleukin 2 and OKT3 monoclonal antibodies. Basically, if you understand the concept, you will know the drugs. Because basically, those are anti-hypertensive drugs come into this class and steroids. So there are certain dynamic auscultation bedside maneuvers that can be used to change the intensity of cardiac movement. One is respiration. I told you left-sided maneuvers, right-sided maneuver increase on inspiration and left-sided maneuver increase on expiration. Isometric exercise, that is hand grip, transient arterial occlusion, pharmacologic manipulation of preload and or afterload. Valsalva maneuver, rapid standing or squatting, passive leg raising and post premature beat. So majority of this, the concept of this is basically they, if you increase the preload or decrease the preload and increase the afterload and decrease the afterload. So what activity does what you should know. So differential diagnosis of new daily persistent headache. Primary is migrainous type and featureless tension type. Secondary is subarachnoid hemorrhage, low CSF volume headache, raised CSF pressure headache, post-traumatic headache and chronic meningitis. So cervical radiculopathy, if C now there is a mnemonic for this. So C5 is biceps, C6 C5 C6 is biceps, C7 is triceps, C8 is finger flexors, and T1 is also finger flexors. So C5 is motor is rhomboidus, infraspinatus, and deltoid. C6 is biceps, pronator teres. C7 is triceps and wrist finger extensors. C8 is abductor pollicis brevis, first dorsal interosseous, and abductor digiti minimi. Abductor T1 is abductor pollicis brevis, first dorsal interosseous, and abductor digiti minimi. Pain distribution of C5 is along the lateral arm and medials of scapula. C6 is lateral forearm, thumb and index finger. C7 is posterior arm, dorsal forearm and dorsal hand. C8 is fourth and fifth fingers, medial hand and forearm. And T1 is medial arm and axil. So this is mostly basically more of like an anatomy chart. This is usually asked for practicals, but also can be asked in exam. So now causes of back pain or neck pain. One is lumbar or cervical disease, degenerative spinal disease like lumbar spinal stenosis with or without neurogenic claudication, intervertebral foraminal lateral recess narrowing, that is IVD intervertebral disc narrow, that is disc osteophyte complex, facet or uncover vertebral joint hypertrophy, lateral disc protrusion and spondylosis, spine infection like osteomyelitis, spinal epidural abscess, septic disc, meningitis or lumbar arachnoiditis. Neoplasms like and metastasis hematologic, primary bone tumors or fractures, so trauma, falls or RTS, or traumatic fractures, osteoporosis, neoplastic infiltration and osteomyelitis, minor trauma like strain or sprain or whiplash injury, metabolic spine diseases like osteoporosis and osteosclerosis, congenital deformity like spondylolysis, kyphoscoliosis, spina bifida occulta, and tethered spinal cord, autoimmune inflammatory arthritis. Other causes of back pain are referred pain from both visceral disease like abdominal aortic aneurysm, postural back pain, psychiatric, malingering, and chronic pain syndrome. So this is a chronology of events required for induction of fever. Now, infection, microbial toxin, mediators of inflammation and immune reaction. There is activation of monocyte macrophages endothelial cells, which activate the pyrogenic cytokines like IL-1, IL-6, TNF, and interferon, which ultimately reach the hypothalamic endothelium and increase the release of PGE2 and cyclic AMP, which will elevate the thermoregulatory set point. And there is heat conservation and heat production, which leads to finally fever. So this is basically the pathogenesis of fever. This is very basic. Right upper quadrant it is cholecystitis, cholangitis, pancreatitis, pneumonia, empyema pleurisy, subdiaphragmatic abscess, hepatitis, and Budd-Chiari syndrome. Epigastric pain usually will be of gastritis, GERD, peptic ulcer disease, pancreatitis, sometimes inferior wall MI, especially pericarditis, ruptured aortic aneurysm, and esophagitis. Left upper quadrant will be splenic infarct, splenic rupture, splenic abscess, gastritis, gastric fever, pancreatitis, subdiaphragmatic abscess. Right lower quadrant is appendicitis, salpingitis, inguinal hernia, ectopic pregnancy, nephrolithiasis, inflammatory bowel disease, mesenteric lymphadenitis, and typitis. Periumbilical is early appendicitis, gastroenteritis, bowel obstruction, ruptured aortic aneurysm. Left lower quadrant is diverticulitis, salpingitis, inguinal hernia, ectopic pregnancy, nephrolithiasis, irritable bowel syndrome, and inflammatory bowel disease. Diffuse non-localized pain is gastroenteritis, mesenteric ischemia, bowel obstruction, irritable bowel syndrome, peritonitis, and diabetes. Malaria, familial Mediterranean fever, and metabolic diseases and psychiatric disease.